I would like to first start off by saying a very big thank you to Dr. Michael Jones, who handled the topic Bloodless Caesarean Section Techniques. And he did a very nice job yesterday, spoke extensively about all the techniques we use to ensure that we have a bloodless field. And we avoid blood transfusions when doing cesarean sections. However, we will not be listening to the same things all over again. We're going to use a slightly different approach in discussing this same idea of bloodless cesarean section techniques, but in a low resource setting, as has been said. We're going to use a case presentation as a sounding board to explain what most of us do. Various definitions exist with respect to what bloodless surgery is in a low resource setting. So what is a low resource setting? That is where we're going to start from. Many definitions are out there about what a low resource setting is. Most people view it as a setting where the cost of healthcare cannot be afforded by the individual or the society. But a more comprehensive definition or understanding of what a low resource healthcare setting is when we look at it from the point of standards. This is a healthcare setting that does not meet the accepted standards of the World Health Organization or any other quasi-governmental organization. Such settings lack usually three basic necessities or three basic resources. The first one is usually infrastructure. Second is material and supplies. And the third one is human resources. So if any of these resources or structures is deficient in a healthcare setting, it becomes a low healthcare resource setting. And this accounts for why even in advanced countries, they can have low resource centers occurring in such areas. The main problem with low resource setting now in our environment is that many of the guidelines that operate in low resource settings are actually have been designed by practitioners or groups who have been operating in adequate or well-equipped centers, such that when they bring those practice guidelines to low resource settings, they turn out to be poorly suited to those environments or may not be appropriate in such settings. So what can we do? Usually, the challenges can be overcome if we look at the human resource in those centers. The human resource can help overcome those challenges that we meet in low resource settings, because the ingenuity and resourcefulness of the human factor, especially their commitment and genuine interest, care, and compassion for the patient, can actually make a difference in these centers. So the answer to how we can still get good or near adequate care comes down to the human resource in these centers and how they can function despite the challenges or lack of equipment or materials. So let us start with the case presentation, and then we can use it to highlight what I've been talking about. The patient we'll be talking about is Mrs. EEJ. She's a 33-year-old gravida 1 para 0+0. That is, she's never had any childbirth in the past, and this is her very first pregnancy. She saw her last menstrual period on the 13th of July, 2021. Her expected date of delivery was on the 20th of April, 2022. She booked at a gestational age of 14 weeks. At booking, she was requested to have an ultrasound scan done, but due to financial constraints, she could not have this done. However, about 3 weeks later, she was able to carry out the ultrasound scan, and the scan showed that she had an anterior low-lying placenta that occluded the cervical os completely. She was counseled about the findings and the implications of these findings for her and her unborn baby. Interestingly, she is a Jehovah's Witness, and she had on her a signed written document that prohibited any form of blood transfusion or blood products, even her own blood products. So with this in mind, we had to work out or modify her antenatal care plan. We rescheduled her visits, changed them from 4 weekly visits to every 2 weeks. She was also placed on frequent hematinics. So she had to use iron supplements and other multivites with the aim of building up her red blood cell, just in case she has any breakthrough bleeding. She was also giving treatments, intermittent prophylactic treatment every 4 weeks for malaria, because the parasitemia associated with malaria could result in anemia. And if she has any form of bleeding, it will actually lead to a compromise in her health status and that of her baby. Following these changes, we then proceeded to monitor her blood level or her hematocrit. At booking, the hematocrit was 35%. Then at 22 weeks, it turned out to be 38%. At 26 weeks, it became 36%. So it rose and fell. Before she could have the next hematocrit done at 30 weeks gestational age, she had a breakthrough bleeding, an episode of bleeding. For this bleeding, she was admitted in a hospital. The bleeding subsided that very day, but she was kept in hospital for 1 week to ensure that there were no further bleeding before she was subsequently discharged home. She was okay for 2 weeks, there was no problem. At the end of the second week, when she returned to the hospital to have a repeat ultrasound scan, she started bleeding again. So because of this second episode, which was much heavier than the first one, she was advised to stay on admission in the hospital. She was readmitted. And this time around, we decided to keep her for 5 weeks because she bled at 32 weeks. We wanted to attain fetal maturity and see how we can build up her red blood cells. So she stayed on admission for another 5 weeks until fetal maturity was reached at 37 weeks and 4 days. At the end of this period, she was counseled and offered the option of elective cesarean section, considering the fetus was already mature. And when we assessed her hemoglobin, it was 13.4 grams, which was a hematocrit of about 40% prior to surgery. The next slide here shows the ultrasound scan that was done. The P we see written on the side there is for the placenta. And then the IO we see is the internal os. So the placenta was sitting squarely, completely over the internal os of the cervix, occluding it completely. When we told her about this after the repeat scan, we then proceeded to invite the consultant anesthesiologist and another specialist obstetrician so that we could have capable hands during the surgery. The plan for anesthesia was to use a regional technique, and then intravenous access was secured while she was in theater. She was monitored routinely with non-invasive non-invasive blood pressure monitoring, heart rate monitoring, and oxygen saturation. The baseline values she had at the start of surgery was a blood pressure of 160/80. The pulse rate was 90 beats per minute, and her oxygen saturation was 97%. Subsequently, we went on to have her surgery, but before then, she had fluid. The anesthesia, like we said, that's the picture of the anesthesia when it was being administered by the consultant anesthesiologist. She had a combined spinal epidural anesthesia. So at surgery, we decided to preload her with 1,500 mils of normal saline, which served to dilute the blood volume in circulation. During the surgery, her blood pressure remained normal, within normal range, and the surgery lasted about 6 minutes. Urine output was adequate, oxygen saturation was adequate. In total, at the end of the surgery, we had infused about 3,500 mils of normal saline. And when we eventually discharged her home on the 4th day post-op, her hemogram was 10.1 gram per deciliter. Post-operative care, which we instituted for her. The next slide showed towards the end of the surgery, the surgical technique that Dr. Michael Jones described, the Gynaecologist incision. What I was trying to picture here was that even in cases where we are likely to encounter massive hemorrhage, the little things we do, meticulous hemostasis, preserving the blood vessels, not cutting them or transecting them, go a long way in helping us with reducing blood loss and avoiding blood transfusion. That's why I have this photo in there of the incision we made and while we were closing, and just to show the vessels that were spared. Post-operatively, we gave her adequate antibiotic cover. She had adequate uterotonic agents administered so that she does not have any episode of bleeding within the first 24 hours in the post-operative period. She was also placed on hematinics to use for the next 90 days. Currently, she's on her sixth week postpartum, and she's been compliant with her medications. So this case serves to illustrate a few things about the pillars of patient blood management. And what are those things that we are trying to illustrate with this case? The first pillar is to optimize red cell mass. The second pillar, which is to minimize blood loss and bleeding. And the third pillar, which is to harness and optimize the physiological reserve of the patient against anemia. So let's look at each one now in detail. For the first pillar, which is to optimize red cell mass, what did we do in the antenatal care period? We tried to detect anemia by checking her packed cell volume or hematocrit, looked at possible underlying causes of anemia in this patient. We did her blood film for malaria parasite, provided intermittent positive treatment, intermittent preventive therapy treatment to prevent malaria, gave her hematinics to restore her iron stores, ensured that she took antihelminthes to kill off any intestinal parasites, encouraged her to improve on her diet so that she could supplement what we're giving her orally. Intraoperatively, still to optimize red cell mass, we planned the time of surgery to coincide with when the hematocrit level was optimal, hematological optimization. So our surgery was timed to coincide when we got a hematocrit of 40%. And then post-operatively, we continued giving her iron supplements to stimulate erythropoiesis and increase the red cell mass. For the second pillar, how did we implement this? The second pillar involves minimizing blood loss and bleeding. During the antenatal period, we tried to identify and manage all possible bleeding risk, which we saw in this case was placenta previa. So we increased the frequency of her visits. We did not have to take so much blood from her every 2 weeks to check her hematocrit, but we did that every 4 weeks. We discussed our plan of delivery with her, which involved surgery, and then informed all specialists who could help us or assist us in handling her case. And there's the option of autologous blood donation, saving, and then maybe later transfusing to the patient. But because she refused or declined this option, this was not done with this patient. Intraoperatively, what did we do? We were very meticulous with hemostasis. We made sure we preserved as much of the blood vessels we came across as possible. We also used hemostats in holding any bleeding vessels that we came across. And we gave pharmacological agents that aided in reducing blood loss in these patients. We used tranexamic acid prior to the uterine incision. We also used oxytocin and ergometrin, which were uterotonic agents that helped contract the uterus and reduce bleeding. Post-operatively, we also continued the uterotonic agents and monitored her for the next 24 hours so that we were very alert to any possibility of bleeding in these patients. We placed her on adequate antibiotic cover that prevented any infection, which could lead to septicemia and eventually anemia and possible hematological compromise in these patients. Then let us go to the third pillar. The third pillar, which is to harness and optimize the physiological reserve against anemia in these patients. In the antenatal period, we gave her hematinics. When she lost blood, we were very prompt in having her admitted, tried to assess the blood loss, did the hematocrit level to be able to determine what was the tolerable blood loss in this patient. And then we were a bit restrictive in our resort to requesting blood for this patient. Although we knew, yes, she did not accept blood, we had to take extra precaution and have her on admission for a whole 1 week. The bleeding subsided within 24 hours, but we didn't want to take chances of her going back home and having a recurrence of the bleeding. Intraoperatively, how did we implement the third pillar of patient blood management? The anesthetists were very helpful in this aspect. They monitored and optimized her cardiac output. They used a regional anesthetic technique that allowed the blood pressure to reduce, which reduced the chances of bleeding for us. And then they maintain adequate ventilation and oxygenation in this patient. During the surgery, she lost quite an appreciable amount of blood, but they were still restrictive in their requests for blood transfusion. They did not quickly jump and pressurize the patient that she should have a blood transfusion. And post-operatively, we were able to reduce her movement, observe her in the ward and in the hospital over 4 days. We were not in a rush to send her home and then have her in a compromised condition. Interestingly, on the fourth post-operative day, when we checked her hemogram, it came to a value of 10.1 gram per deciliter, comparable to a hematocrit of 30%. So in a poor or low resource setting, what can we do? What is the most important factor that helps us to cope and offer good treatment to our patients? It comes down to the humans, the people involved. If we are committed, if we are willing and compassionate and ready to go the extra mile to apply ourselves diligently and meticulously, take care of our patients, give attention to the small details, go the extra mile, we'll be able to accomplish great good for our patients and take care of them. We may not have all the materials and supplies that are required in a well-established center, but with the low resource setting and the low resources available, we can still give adequate care.